Hey guys, and welcome to the ECG of the week. Take a second here to pause the video and remind yourself of this week's clinical vignette. Perfect. All right, so let's take a look at this ECG. So we're going to follow our 6-step method to interpretation, and we're going to start here with our rhythm. So looking at this ECG, we've got a beat here, here, here. Then a nice gap, followed by beats here and here. So if we're looking at that, it looks like we have an irregular rhythm, but we've got a gap followed by a group of beats here and a group of beats here. So we can go ahead and call this a regularly irregular rhythm. So moving on to our rate, we know we have an irregular rhythm, so we've got to use our multiply by 6 method. So we're going to go to our rhythm strip, look for all of our beats, and we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So we're going to multiply that by 6, and that gives us about 66 beats per minute. So going on and looking at our P waves. So we're just going to look and make sure that we have P waves. Looks like we've got one here, one here, one here, so on and so forth. And then we can move on from our P waves and look at our QRS complexes. So we should have a P wave followed by a QRS complex that is nice, tall, and narrow. And if we're looking at them, we've got a QRS complex here, here, and here. And they all appear to be less than 120 milliseconds, so we're not going to say that we have a bundle branch block there. So if we're looking for our PR intervals now, our first PR interval here, but then we've got this P wave without a QRS complex. So if we zoom in, we're going to look at the PR intervals in this little group of beats here. So first PR interval looks to be about normal, probably around 180 milliseconds. If we move on to our next one, we've got that, that, and that. And if you look, it looks like we're actually seeing an elongation of our PR intervals. So we're going to go ahead and call them varying for now. Final step, we're just going to be looking at our ST segments, just making sure there's no acute coronary syndrome, and here, 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 here. Looks to be about baseline. We're not seeing any real elevation or depression, so we're going to call those ST segments normal for now. So, just to review then, guys, our ECG findings, our rhythm was regularly irregular, rate 66 beats per minute, P waves were present, QRS complexes were nice and tall, less than 120 milliseconds. Our PR intervals were varying, we had no ST elevation or depression. So all of this leads to an interpretation of an atrioventricular block, Mobitz type 1, which we also call Wenckebach. So let's talk a little bit about that. So we're moving on to here. Atrioventricular blocks, as the name suggests, are just any delays in the conduction system. So normally we're going to be sending a signal from our SA node down to our AV node and out through the bundle branches to the ventricles. So what's happening in AV block is we get a delay, or in some cases a complete block, of the conduction from the SA node through the AV into the ventricles. So important cause of this include drugs, increased vagal tone, inferior MI, or trauma. Generally, we're going to have some amount of fibrosis, which is causing our signal to slow down. So these are broken up into types based on their severity. Our first one here is type 1. This is pretty simple. So we have a little bit of damage occurring in our AV node here, which means that as we send our signal down from the SA node, hits the AV node and it slows down. So our atria contract, small delay, and then the signal goes out into our bundle branches and our ventricles contract. So all AV block is a widening of our PR interval that we see on ECG. So, like I said, there are several types of atrioventricular block, and our type 2 is actually broken up into 2 types. So Mobitz 1, or Wenckebach, is what we focused on. Again, we've got a delay occurring, a little bit of fibrosis in the AV node, and as our signal's coming down through the SA node to the AV node, we're getting that same little bit of delay, then our signal's being sent on. But what's occurring is every time we send a signal on through the ventricles, our AV node cells are taking longer and longer to be ready to send the next signal. So what we actually have is atrial contraction, signal being sent through the AV node, and each time our PR interval is getting longer and longer, so that finally we send a signal to the AV node and it is not conducted through the ventricles. So we call this a block or dropped beat. This can be seen on the ECG that we did earlier, in which we have a P wave followed by no QRS complex. So moving on from there, Mobitz type 2, our block is actually occurring lower down in the bundle branches. So we're sending our signal down again through until we hit our block. And the important thing to note between Mobitz 1 and Mobitz 2 is there's not actually a prolonging of our PR interval. So we're going to have a regular PR interval, but we're going to have dropped beats occurring regularly throughout the rhythm. So the PR interval is fixed, but as we're sending our signals down, atrias contract at regular intervals. We're not going to be having our ventricles contract. So this is just a much higher risk for hemodynamic instability or sudden asystole. Finally, we've got our type 3 or complete AV block, which, as the name suggests, we're sending signals down, gets to our bundle branches, and there's no conduction of signal. So what we're going to see on ECG is actually two completely separate rhythms. We're going to have our atria contracting at a rhythm from the SA node, approximately 60 to 100 beats per minute, but then our ventricles are going to be contracting completely on their own at about a rate of 30 to 50. So the rates will be regular in relation to each other, but you're going to see essentially just beats happening all over the place with no coordination whatsoever. So as far as interpretation tips goes, guys, we're focused on Mobitz type 1, Wenckebach here. And when you're going through, just make sure that you're ticking off your R waves, getting that other sheet of paper, doing about 3 and moving along, checking for regularity. And the big thing is you're going to look for grouped beats. That's going to be one of the biggest things that's helpful. And if you follow our 6-step method to interpretation, then you should be able to nail this one down. So let's go through one again. This is the same one from earlier. Even just looking at the rhythm here, we've got group of beats here, group of beats here. That's going to lead us to start thinking about that we're having a drop beat somewhere. So if we zoom in, we've got, looking at our PR intervals, got one here, and then here we've got an R wave without QRS complex. So just looking at it, it looks like we have some progressive elongation followed by a dropped beat. So that's pretty pathognomonic for Wenckebach. Finally, we've got our last example here. Again, we've got our grouped beats. The only difference here is, we have a group of 4 beats and a group of 5, so there doesn't have to be complete regularity to the number of beats before the drop. Just something to look out for. But if we zoom in on that group again, look at this PR interval, the next, we see again we've got our elongation. We get a P wave here, but no QRS complex following it. So that's going to lead us to be thinking Wenckebach one more time. So big takeaway here, guys. Just remember AV blocks are often asymptomatic and incidental findings, and looking at ECGs for type 1, you're just going to see your increased PR interval. It's just that delay through the AV node. Type 2, or Mobitz 1, is prolonging the PR interval with a regular drop beat. That's what we focused on here today, and one that I think is a good place to start when you're looking at atrioventricular block. Type 2, Mobitz 2, that's where you have your regularly dropped beats. Now you can see that progressive PR interval elongation, you're just going to have beats dropping out. And finally, type 3, you got complete AV dissociation. So you've got an atrial rhythm occurring with a completely separate ventricular rhythm. It's going to be pretty random and haphazard, but they should be normal to each other. So just make sure you tick off some of those P waves and some of the QRS complexes and look for the regularity there. That's it for today, guys. Hope you have a good day.